Good afternoon, hello, and welcome to episode 60 in this RSM COVID-19 series. I can't believe it is the 60th one, and this is so timely, the race to vaccinate a country. The announcement yesterday that we would pass the 10 million mark was such a remarkable achievement, given that this time last year, few believed that we would even have a vaccine by now. I'm going to race through this introduction because there are so many questions, but there is a Q&A feature on this. So if you want to ask a question during this session, please pop it in there. And I have a whole list that have already come in too. So racing right through, let me introduce our speakers. Danny Mortimer, Chief Executive of the NHS Confederation, and Professor Sheena Cruickshank, Immunologist and Professor in Biomedical Sciences and Public Engagement at the University of Manchester. So welcome and thank you both of you for doing this. I'm going to start with you first of all, Danny. I mean, we have seen the 10 million mark, and as I said, remarkable. There is a deadline, and I don't want to start raining on anybody's parade right now, but this deadline of the 15th of February to have immunized the priorities 1 to 4, so the people who are 70 and over and the clinically extremely vulnerable. Are we going to meet that deadline?
Hi, Victoria. Hello, everyone. Thank you very much for having me. The deadline that's been set by the government is for the vaccine to be offered to everyone in those groups. And I think there is increasing confidence that yes, that will happen. There are two big issues that our members worry about, and we represent trusts and primary care networks and clinical commissioning groups and health boards across England and Wales and Northern Ireland. Two things they flag is that there is still far more uncertainty about supply than we were led to believe there would be back in January when the Oxford vaccine was approved. So there's still disruption and uncertainty there, particularly for primary care settings. And the primary care settings have probably given more than 70% of the vaccine doses actually of that 10 million. And the second is there are obvious issues about hesitancy, particularly for ethnic minority groups. And we're seeing that in the NHS workforce, and we're obviously seeing that in particular in the communities that we look after. That's not a new thing. It's there for all vaccines, and there's obviously a whole set of historical and trust issues for some communities in relation to healthcare in general and vaccines in particular. But there are a particular set of challenges there, and there's a lot of work going on in that space. We host the Race and Health Observatory, which has been funded by NHS England, for example, and they're doing some work with the School of Hygiene and Tropical Medicine to look at the workforce issues, and there are similar conversations going on around the community issues. But that, I know, is an increasing area of concern in terms of those issues. The supply issues are really important, obviously, as well, and they've been rehearsed, I think, fairly well, particularly of the challenges that the EU countries are facing. But we get regular reports of places not getting the doses that they still need to vaccinate people, or getting greater supplies of the Pfizer vaccine than they would when they would prefer to have more access to the AstraZeneca Oxford vaccine because of the particular populations they need to vaccinate. So those are the uncertainties. But like you said, to be at this kind of stage at the beginning of February is remarkable. It's magnificent. People have worked their socks off in terms of the delivery, and obviously the scientists and June Rain and her colleagues at MHRA and Kate Bingham and her colleagues at the task force. It's been a remarkable effort to get us to this stage.
Can I just quickly pick you up on, as you were talking about some of the vaccine hesitancy, and we'll come back to that a bit later. But is there enough data being collected to actually tell us precisely where this issue is a problem, in precisely which communities it's a problem? I mean, how do we know, how can you resolve it without that data?
So the simple answer to your question is no, there hasn't been enough data collection about those issues sort of systematically in the first 2 months of the vaccination programme. NHS England have committed to change that going forward, and that's something that I know my colleagues at the Observatory pushed for quite hard. So that is an important change, and it's a lots of things were done at pace to get the vaccination programme, but it's really unfortunate that was missed. What we are getting is feedback from our members. So employers, healthcare employers are reporting very different rates of take-up between their white and non-white staff, very different rates. Particularly our primary care network colleagues are also reporting very different take-up in terms of appointments that they're offering. And they're doing a lot of work themselves, of course, to engage with their local communities and community leaders to try and get through and to explain to people what's going on, and to also challenge some of the misinformation there is about the vaccine not being halal or whatever it may be. There are a whole set of things that have swirled around the vaccine that need repeated discussion and challenge and explanation, importantly. But no, the data collection has not been to date systematic enough. And of course, there's a broader problem in that there isn't as yet a national kind of breakdown of all the factors that lie behind the kind of magnificent 10 million figure. And we do need to understand, are there particular challenges in the age groups? Are there particular challenges for communities? Because yes, that there may well need to be some targeted action in this next couple of weeks, but there also may need to be some targeted action in the longer term. When we were chatting beforehand, Sheena made a really interesting point about advice from her patient advisory group about access to pharmacists in particular, that works best in some communities. But again, we need we need the data, we need the kind of rigorous evaluation by people like Sheena and her colleagues in particular to make sure that we are targeting the programme effectively, and particularly targeting it for those communities that are typically kind of underserved by the health service.
I think that the issue of trust, of course, is central to all this. And actually, Sheena, I wonder if you could explain something for us. There has been this controversy, I would say, over the decision to extend the time period between the first and second dose to 12 weeks. We saw the Oxford paper earlier this week looking at the Oxford AstraZeneca vaccine, saying that actually it does give you very good protection. But then we had some data out of Israel, which an enormous number of people seem to have leapt on. Can you clear up for us, or have a go at clearing up for us whether this was the right decision?
I think the critical thing is that what we're trying to do is give as many people as possible a good level of protection. And with one dose, your immune system is getting exposed to the things that it needs to have to start creating, for example, antibodies or the T cells that are very important in killing virus. And although initially immunologists in the British Society for Immunology were a little bit reticent about changing the regime, we understand the need that it's better to have everybody getting partial protection before they get the bigger amount of protection from the second dose. So with the latest data from Oxford, what's really encouraging is it actually looks like the response is better from delaying the doses by 12 weeks instead of the shorter interval. So that suggests that we've got even better protection. I think it was the Johnson & Johnson vaccine also looked like it produced a very robust response quite quickly. With Israel, it's differences in how they're looking at the data. If you look at very, very early on in the immune response after COVID, then we wouldn't expect as immunologists to see much of an antibody response. It takes a little time for your antibodies to get going. And also a reanalysis of that data has suggested that actually some people immediately after they get the vaccine may be doing slightly more risky behaviors because they feel secure, they feel safe. So that might be one of the reasons why we're seeing a little bit of an increase in infection. But when you're looking at the data, it's really, really important that you're looking at like for like. Are you looking at a suitable time point after infection that we expect to be seeing a measurable immune response? And are you looking at the same types of infection? So for example, saying everybody, whether they're asymptomatic, is causing an effect, or whether they are having a much, much less severe disease is having an effect. And people are using different measurements in the data. And in Israel, they were looking at just anybody who had a positive result at any point. And that's not the same. So I'm quite optimistic, actually, that this longer gap is going to be enough to lessen the severity of the infection, but it is important that you do take up the second vaccine.
Yes, that paper did seem to show that in that first 8 days, isn't it, that the over 80s group was going out and partying wildly and not obeying all the rules that we've been told they must. Can I ask you, just on the new variants, of course, is that there will need to be some modification of the vaccines. And I wondered whether that has implications for approval. Do you, every time you modify a vaccine, do you have to go back through the same regulatory process?
That's a really good question again. So one thing is that we are starting to get data on how good the protection is from some of the other variants of the virus. And it looks like, particularly for the South African strain, there might be quite a sort of decrease in efficacy, but actually it's still enough to give you some protection. If they do need to redesign the vaccine, and I believe that the Oxford group are already looking at doing that for things like the South Africa variant, then yes, it will have to go through some approval. I don't know whether it's have to go through the phase 1 and phase 2, but we've already seen how agile we can be at these things. And perhaps it will end up in the same sort of position as the influenza vaccines, where we look at modeling and we're just adjusting the vaccine accordingly each year. But I wouldn't want to say definitively about the legislation at this point. I'd have to double check on that.
Danny, I just wanted to come back to you. There's a question that a number of people have wanted answered now. Is it a coincidence that the UK vaccination programme seems to have been successful so far and was not handed over to private providers to deliver? And of course, there has been a lot of discussion about the test and trace and well, the testing system particularly. Well, what are your members' views on that?
It would have been impossible for anyone other than NHS organisations and NHS contractors to deliver the vaccination programme. The primary care role is both, as I said, particularly in this first phase, is huge. 70% or more of the vaccines. But actually, of course, our colleagues in primary care and their teams, whether it's general practitioners or practice nurses, they have years of experience of delivering vaccination programs. We have the public health infrastructure to organise the vaccinations for our children in particular, but also for the rest of us as well. It would have been, I think, an impossibility for anyone else to come in. All the staffing resource, all the expertise, all the IT, all the infrastructure is an NHS one. And whilst there has been, obviously, people like yourself, Victoria, have covered the kind of role and contribution that people like the armed forces are playing, that's very much just supplementing an existing capability that the NHS has had since the day it was founded, basically. So yes, we could only have done this. The argument for test, trace and isolate is more complicated. I think the argument around the testing capacity was that they needed to go to the private sector to rapidly increase the testing capacity. The argument about the centralised versus localised contact tracing, that's been well rehearsed, and our members' view, as I think local authorities would also argue, is that, again, there was enormous expertise there in local teams, and it would have been better to supplement the local teams, which I think is probably the place that Baroness Harding and her colleagues are getting to now around contact tracing. And of course, the biggest challenge that we're facing is that there seem to be significant numbers of people who, for economic reasons, aren't coming forward to be tested. So the contact tracing can't even take place because, you know, they're worried about losing their jobs or their livelihoods, or they don't have access to the kind of support that people might have if they can access furlough or good sick pay schemes. So that appears to be the most material issue now. And whether it was the NHS running it or whichever combine of private companies are delivering it, and that problem is in the hands of the government to resolve in terms of how it supports people to isolate safely.
Just on the vaccination program itself, is there any argument for giving health workers, particularly frontline health workers, that second dose earlier? Where do you stand actually on the 12-week regime?
I mean, as I understand the science, it's as Sheena described, and the requirements of the JCVI apply to all the high priority groups, which rightly include social care and health workers. There have been
a different way is that we saw, especially at the beginning, some GPs, for instance, or health workers putting pressure on trusts or whatever to ignore that 12-week regime because they felt that it hadn't been proved and that they had committed to their patients to continue vaccinating. It caused a lot of distress, I know, certainly among some of the GPs that I know, that they were being asked to.
Yeah, and there's a couple of things. There's a couple of things here. So I think that the first is I've worked in healthcare long enough to know that debate is part of how we get to the right place. But I also know that actually trusting our more expert colleagues, and I'm a non-clinician speaking to an audience of clinicians. I've had 30 years of experience of trusting the judgment of my clinical colleagues. That's also part of how healthcare progresses. And Wei Shen Lim and his colleagues at the JCVI have set a policy that Sheena has explained far better than I ever could. They use their expertise and their judgment to set that. And that applies for all the high-risk groups. I absolutely accept that for the BMA and others, they have to have the right on behalf of their members to challenge that with JCVI and the 4 UK governments. But it's not appropriate for them to put pressure on my members to deviate for the policy only for healthcare staff. I think for our general practice colleagues, the biggest source of frustration for them was that the policy was changed immediately before the New Year bank holiday weekend, and lots of patients were booked in for those first couple of weeks in January. And both the logistical toll of having to kind of rearrange those patients, but also the emotional toll of ringing up your patients and say, look, I know we've booked you for next week, but actually we're pushing it back to March because this committee's changed the policy. It was too quick and it was enormously disruptive, and people were really worried about what they'd have to do. A lot of people were rebooked, but I think we all know that some people weren't rebooked because it just couldn't be done over the course of that New Year bank holiday weekend. And of course, people didn't want to. Some clinicians took the judgment, which eventually they were supported to do, that it wasn't in the best interest of those patients they'd already booked. But we're in a place now where the second dose policy is kind of being universally adopted. The way it's being rebooked varies between the mass vac centres and the primary care sites, and that causes some concern, I think, for patients in particular, because you tend to get both your doses booked if you go through a mass vac centre, but you only get your first dose booked when you go through a primary care network site, and then there has to be a second booking that's made, through next month in April for patients. And that's also unsettling people slightly.
Should that not be joined up by now?
Yes, that would be our view. The system that's being used, Pinnacle, I think it's fair to say there are some teething problems around that. The data transfer from the mass vac site to the primary care colleagues is slow. So I wouldn't, if I was a GP, I wouldn't know, Victoria, that you'd been booked through a mass vaccination centre until 48 hours after you'd had your first dose. So the risk is that my admin team ring you up to offer you an appointment with your local, your most local GP site, and you've already been booked through the mass vaccination centres, there's some time is wasted, some frustration occurs. So our members are suggesting some ways in which there could be a kind of clearer division of labour between the mass vac centres and the primary care sites, particularly as the programme expands. I think we're all expecting the numbers to increase even more than they have done as there's more certainty around supply. So yeah, there are some things that could be sorted out around the tech, and there are some things that could be sorted out around the coordination and division of labour.
Well, I wish I had been booked. I'm looking forward to it. Sheena,
we're too young.
Not quite. Sheena, can I ask you? We also have today the announcement of a trial that's going to combine these two of the vaccines, the Pfizer-BioNTech and the Oxford AstraZeneca. I know it's not your trial, but if you could explain to the people listening, and what would possibly be the value of this, and what can we learn from doing this?
I'm absolutely delighted that they are doing this trial now, because it's something that we were discussing last year in our community of immunologists, that this would be really useful to do and to monitor to get that kind of data. The potential advantage of doing this is that we are potentially maximizing the resources that we've got, because this could be logistically better for people, giving them the best chance of getting 2 doses. But it does give us a chance of perhaps even getting an even better immune response. The 2 vaccines use slightly different ways to invoke and kind of charge the immune response up, even though they're using relatively similar targets to actually sort of stimulate specific responses from the immune response. So the advantage of that might be that we could get an actual better response. We have to wait and see. It certainly wouldn't be expected to be a worse response. So at the very least, I would anticipate it would be the same, if not better.
I have literally just done an interview on this, so it's quite fresh in my mind. But one of the issues that was brought up actually is, of course, not just for our country, but that this could have implications internationally. And I think there has been a lot around about the race to vaccinate ourselves, while not making sure that the vaccine's getting to developing world countries. What is the importance of bringing back that debate and opening it up to its universality?
Unless we can protect everybody, we can't protect ourselves. It's as brutal as that. While this infection is able to thrive in certain parts of the world, we're increasing the likelihood, I would say, of getting these mutations that we're seeing at the moment. And we are continuing to allow a reservoir for the virus to flourish. So we absolutely have to address access for all. We have to be supporting the WHO, we have to be supporting these universal campaigns. And that is why some of these vaccines, such as the AstraZeneca vaccine, are so interesting, because of course they are more robust. They can be transported more readily. And they're cheap. We've got to look at the cost of these. The best vaccines for developing countries where there's going to be infrastructure issues are going to be vaccines that can transport easily, can be readily got to the areas that they need to, because remember, some of these places may not have good, robust supplies of electricity. We also need to look at the cost issues. We can't just be, companies can't just be making massive, massive profits out of this. We're seeing a state where a lot of the developed countries have booked in so many vaccines that they can vaccinate the population over, I don't know what the actual figure is, but certainly more than they need. And we need to be making sure that those vaccines aren't sequestered and kept by these countries. They are indeed shared. And again, if we know which vaccines work well together and can optimize it, this could be important around resource implications for resource poor countries.
There's another question that's come up, which pertains, it's a universal question again too, but how robust do you think is the evidence? And we've seen one paper this week that seems to suggest that that these vaccines, or one of the vaccines, the Oxford AstraZeneca vaccine, is very good on transmission, on preventing transmission. were you, it's not peer reviewed, that paper, but were you persuaded by it? And do you have a feel that the vaccines, all of the vaccines, will perhaps have some impact on transmission?
That is a good question. So the real concern initially was that these were not going to be transmission blocking, and we weren't really measuring efficacy on them being transmission blocking. So transmission blocking means that, you know, the virus is just completely killed as soon as it enters the body. And there was always concerns that, for example, in the upper respiratory tract, particularly around the nose, that virus could still be replicating and being transmitted. I would not anticipate that these vaccines are going to be completely transmission blocking vaccines. I think it is encouraging that we're seeing some reduction in transmission from this initial Oxford data. We do have to monitor what's going to happen. This is really important data to get for all the vaccines, in truth, but because we don't necessarily anticipate that neutralizing antibodies are going to stay high for the entire period, you know, years and years and years, that might mean that they won't be transmission blocking, because neutralizing antibodies are a good feature, a good indicator that a vaccine is actually going to be able to do that. And some of the data is suggesting that antibodies do gradually decrease over time. However, you have the memory responses from our immune cells that are then able to generate T cell responses to kill virus and B cell responses to make more antibody when we need it.
Yes, there's been a lot of discussion recently too about forgetting about the T cell response. Could you just give us a quick lesson in T cell response?
T cells are absolutely critical for an effective immune response. In fact, in truth, and probably my B cell immunologist would kill me for saying this, they are more important than the B cells. You've got several types of T cells. One of the types of T cell actually helps B cells make antibody. That's why I'm saying they are more important. So without those T cells, you don't get that good B cell and antibody response that people talk about. The other type of T cell is developed exclusively to be able to kill virally infected cells and virus, and that's what its job is. And these immune cells are designed to work together as a partnership. And it's that partnership that is so critical for dealing with infections well. Does that help make sense?
That's perfect, and it is all the briefings that we've had over the past few months on this, and it's been drummed into us to not just look at that immunological response, but also the T cells. Danny, I wanted to ask, one of the things that certainly we in the media have noticed now is actually the fatigue of many of the health staff, probably all of them really, and the distress and so on. And what we're asking now is for many of them to wait a little bit longer to be vaccinated themselves, to have the full vaccination, so the 2 doses, but also to step up and keep this vaccination program rolling. So I think lots of people are thinking, all right, well, it will be finished by March, but there's every chance, isn't there, that it will happen every year, that we'll have to come back. How is the NHS going to cope when it is so exhausting?
The kind of immediate issue is that, you know, how do we build in that time for recovery and decompression for teams, and that's teams right across the board. I think you're right, Victoria. You know, we've rightly focused on our colleagues in critical care settings, you know, who are looking after the sickest patients and probably dealing with the highest levels of death. But actually, the impact's being felt right across the board in terms of changes people have made to their work, just the sheer amount of hours they're having to work. In hospitals, out of hospitals, GP surgeries in particular have really obviously ramped up what they're doing now in terms of a 7-day-a-week vaccination program. So that, you know, that the enormity of the effort that people are putting in, there's got to be some recognition of that in the short term. It'll take us a little while to kind of gear things back up, and then in the longer term, you know, the vaccination program and Professor Cruickshank rightly touched on the fact that we'll probably be in a situation where we'll be repeating vaccinations for people the fact that we know that the virus is having a long-term impact on people's physical health, that we're seeing emerging demand in terms of mental health because of the virus, and that'll only be exacerbated because of the recession that we're in and will be in for some time. There's got to be a resetting of what our view would be, a resetting of what it is the NHS can deliver, and some quite difficult conversations with the public about what it is we can achieve, particularly between now and the next election, when NHS waiting times and all those things will rightly be a subject of concern. But there's only so much that our workforce can do, particularly given, we've talked about this before, you and I, before we even went into the pandemic, we were 100,000 people short. We were 40,000 nurses short. We had a variable distribution of medical staff across the country and between specialties. All those things need long-term solutions, frankly, but are also significant inhibitors of our capacity. If we run the vaccination program as we are doing now, that takes people away from other things that they should be doing, and primary care in particular will going forward have to find a balance between all the other public health programs that it runs, all the other vaccinations and screenings that they run, and this vaccination in particular. So there's a whole kind of reset of expectations for the NHS as a whole. And again, I think it's in every part of the service actually that we've got to do that. And the government have got to be, I think, pretty upfront with the public about that.
There's actually a question that comes off very nicely off the back of that, which is, it is indeed a race against time. Why then has the NHS decided to spurn 24,000 retired doctors and to prefer firefighters? I think this is in order to vaccinate. There has been an issue, I know, with trying to get volunteers going through the approval system. I had thought that had sorted itself out, but maybe not.
So, there's been the two things. I mean, I think back, particularly in the spring, the national system for drawing people in was much slower, and I think people who returned to registration understandably got a bit frustrated because actually the urgency that was apparent in March didn't translate into them necessarily being contacted. And of course, back in the spring, you look at the experience of the spring in activity terms compared to where we are now, actually it's much worse now. But that system, and I think there has been a report published on that, it's had some coverage in the press, that system didn't work effectively enough. It was far too complicated. And then you've had this second experience with the vaccination program where I think we've lost some of the volunteers because actually some of the kind of mandatory training requirements in particular that were set weren't thoughtful or proportionate, frankly, Victoria. And that has been revised, and that is drawing people in far more effectively. We're not in a place at the moment, partly because of the supply issues I've talked about, where we need to draw in lots and lots of extra people. The future phases, when we go out to increased numbers of people and the supply becomes more certain, that's when we'll need the support of those volunteers. But again, the risk is that collectively we've raised people's expectations before Christmas that they would be desperately needed now, when actually it may well be May, June and July when we really need the help, because we're expanding the number of mass vaccination centres to get through as much of the population as possible. The firefighters bit, forgive me, I don't know what the specific there is.
Around firefighters giving vaccines. And you seem to be suggesting that perhaps announcements should be made more appropriately when everything's ready on the ground than perhaps prematurely, but that might be a more political point to make. Sheena, I just wanted to come back to you because there is on the questions, there is the what is the threshold for herd immunity in a population and how do we get there? Now, I've heard this question asked many times, and I'm not quite sure that I've heard anybody prepared to commit to it, but perhaps you could give it a go to satisfy at least 9 people who want this question answered.
Well, herd immunity, of course, refers to the number of people that will need to be vaccinated in order to protect those who cannot be vaccinated. And this varies depending upon the virulence of the pathogen, the virus in this case, and the vulnerability of the population. I think the figures I've seen usually look at a ballpark of around 70 to 80%. This could be changing because, of course, we are seeing more virulent, potentially pathogenic versions with this Kent variant and also the South Africa variant. So I think it's something that it's difficult to give a firm figure on, because it may have to change, because obviously things like measles, we know very famously, has to have a very, very high threshold for herd immunity of closer to around 90% because it's so infectious. So I'm hesitant to be any firmer on that, but we do have a little way to go before we are achieving that, even with the high levels of infection that we're getting at the moment. And obviously infection, and I've said this before, infection is not a great way to get herd immunity. It's far too risky. It should never be a strategy.
There has been some discussion too around people who have already had COVID seeming to have a really good response to the COVID-19 vaccination, or the first dose. Let's be specific about that. Would that be what you would have expected to see? And then just to add on to that, there is another question here saying that if we have a shortage of doses, or we're having the problem with some of the rollout, what would be the benefit then in giving some people some antibody tests, and then they could wait until later to have their first dose?
Okay. In terms of people having a good response if they've previously been infected, then yes, that could well make sense. When we're monitoring the immune responses to COVID, we're seeing quite a broad panel of responses in terms of the things that our T cells and the things that our B cells are recognizing. And there are some targets that seem to be particularly good targets for our immune cells. So you see more of the immune cells doing that. So it's important to be aware that when you have an immune response, you don't just have a response to one little tiny bit of the virus. It is a little bit broader than that. And so the idea then is perhaps with a vaccine, you might be topping that up, but it may be that you haven't had a very good response from your initial infection. Therefore, you need the vaccine to make sure that you did. So we did have some cases that were monitored in the early days that suggested that perhaps they weren't having a robust adaptive T and B cell response. So I think for that reason, it's too problematic to start picking and choosing who has been infected previously gets the vaccine. We also know that there's a lot of concern about some of the how long lasting the antibody results are. So just because you don't have a measurable antibody response may not mean that you had a good immune response, because you might have had a good T cell response. And equally, we know that a whole bunch of people from the very first wave of infection will never, ever have had a positively identified infection, even though they almost certainly had that. And I count myself in that group. I almost certainly had COVID, but it was never diagnosed. So where do you draw the line, I think? I think it's too difficult to try and do that.
Can we just look at too about this controversy about the over 65s and the Oxford AstraZeneca vaccine? Now we've seen that France and Germany and some other countries, maybe for political reasons, who knows, but have said that they're not going to vaccinate the over 65s. Well, what is your view on that?
Every country is going to come to its own decisions. With the Oxford AstraZeneca trial, they have tested in a good number of people, And it has to be said that the majority so far have been in the under 65, but several thousand have been tested in the over 65 group. Ideally, in any vaccine trial, you are trying to get as broad a demographic as possible. Over 65-year-old people may well have a less effective immune response, so they may be less able to generate a good T and B cell response. So that's the only concern, really, is that they might not be generating such an effective response. So I guess what these countries are doing is they're going, well, we know we've got the data for the Pfizer vaccine, so we will just do that for the Pfizer vaccine. But it's not to say that they will not respond well to the AZ data. Certainly the smaller group that they have, there is a response in the over 65s. And I believe the Sputnik data, when I was looking at that recently, that also primarily was in younger individuals, that trial. The sort of subset that were looked at in the older group was much smaller than the rest of the group. It's just unfortunate, the nature sometimes when you're recruiting people, you're not always recruiting the variety and the demographic that you want, even though we've seen an amazing response from people to get involved in vaccine trials. If all vaccine trials had this sort of response, we would get the data so much more quickly in all cases.
I think that's an important issue, isn't it? Because it comes back to what I was saying at the very beginning about trust. And so you are asking people, older people, to say, trust us, even though we can't give you the most robust figures, but we need you to have this vaccine because you are the people most at risk. And I don't quite know, it seems to have gone very well, but I don't know how you get around that.
I think it's like looking at the relative risk. I mean, they have tested, I think, what, 6,000-7,000 people. So it's not like it's not been tested in older people. But the risk of getting the infection and having the most severe results from the infection, we know older people are very, very much more vulnerable. And then if they have other health effects, such as issues like obesity, diabetes, they are even more vulnerable. So they are the most vulnerable from the side effects, the very serious effects of COVID infection. And therefore, I think they should be prioritized to try and protect them from getting severe COVID. We're not trying to protect them from getting the infection per se, we're trying to prevent them from getting severe COVID. And all the data that's coming in so far is suggesting that that is working by and large. So that's really, really good news for those individuals. And that also reduces the strain on the NHS.
Just very quickly, Danny, I just wanted to come back to you because we're about to run out of time. These sessions always go so quickly, but I just want to come back to the Black and Asian and ethnic minority issue about vaccine hesitancy, and we're seeing some quite worrying figures on this. Can you give me, this might be a bit unfair just off the top of your head, but can you give me some examples of what the NHS could be doing, both for its staff and for patients, to persuade these communities that they really do need to have these vaccines?
So there's a few things. I think the first is that there are clearly some practical points about where vaccination sites are deployed and their accessibility. The point that Sheena touched on, and that I referred to around pharmacists, for example, that there's a lot more work to do there. That's the first thing. And the second thing is that there is, I think there's a really good mix of national dialogue by visible public figures, but also the on-the-ground engagement with communities. And again, my GP colleagues are really, really vital to this because they're trying to use their existing relationships to build on these things. The third thing is repetition. This is about repeating the messages, repeating the reassurance, dealing with the misunderstandings and misinformation, but doing that in a kind of in a repeated way and using as many channels as possible to do it. Twitter and social media are great, but they may not be the best way of reaching some communities, and there's a whole kind of effort that's needed there. But it will be needed repeatedly for the coming months.
I was just going to add that the British Society for Immunology has done a lot of work on this, and we have a number of resources that are available to give advice on how to have those conversations, as well as resources that perhaps have pictures rather than words, because often there are English barriers as well. So I would definitely urge people to look at those free resources. Sorry, Danny.
No, that's fantastic. Thank you.
Well, I'm so sorry, but we have come to the end and there were so many more questions. I have tried to get through as many as I possibly could, but thank you, Danny and Sheena, for a really enlightening session. And the Royal Society of Medicine would like me to say that the next COVID-19 webinar, which is next Thursday, the 11th of February, will be on allocating scarce ICU beds in a crisis and will feature Professor Tim Cook, Dr. Musha Qureshi and Dame Jane Dacre. So that will be as equally as interesting. But thank you very much for your time and thank you for attending.